All right, so my introduction, my personal introduction, this is Dr. Gangahar. He's a thoracic cardiovascular surgeon that really encouraged me and influenced me when I was in high school. I thought I wanted to be a thoracic cardiovascular surgeon like Dr. Gangahar, and I was fortunate enough to be mentored by him, volunteered at Bryan Memorial Hospital in the cardiac wing, and spent some time taking patients from their vehicles up to the clinic. They were getting stress tests and things like that, and so really experienced the hospital early on. Came to the University of Kansas, so rock chalk, to get my mechanical engineering degree, because engineering and science was a passion of mine. At his request, he actually said the fluid dynamics and stuff, he wishes he had that education. So I thought engineering and pre-med, let's do that. Thank you, Dr. Gangahar. Organic chemistry 1 and 2 were some of my favorite classes here. And I've been fortunate that in my career, I've been able to merge my passion for medicine, my passion for design and engineering and science by working with surgeons, designing operating spaces that they don't look like that anymore, and working on healthcare projects for really the majority of my career. So to know BranchPattern is to know our purpose. BranchPattern's engineers and scientists are really passionate about improving life through better built environments. And I should say, this was our title slide, and I just wanted to pay homage here. So that's we still call that the Oculus, right? That's from block school. So Steve McDowell's probably drew that on a napkin, and then it became reality. So I just wanted to say that. Okay, so in order to create ultra sustainable projects, in order to push the envelope like you saw in the first 2 presentations where you have to push the envelope, we at BranchPattern want to do that at scale. I mean, that's what this purpose means to us. And so every one of those AIA Code top 10 projects followed an integrated design process. In fact, the AIA put out a research study, a survey where the highest performing projects follow an integrated design process, a human-centered design process. So at BranchPattern, to know us is to also sort of know that that's the quest that we're on. We got together and defined for us a process that our engineers, our energy and ecology practice, our building science practice, and our technology and acoustics practice could take all of their specialisms and services through. So we call it the DIVE project framework. Every project starts with discovery at BranchPattern, and that's where we learn as much as we possibly can from the diverse group of stakeholders, the architects, the clients, the maintenance person. We try to learn as much as we can. We learn about their values, that sort of thing. And then through our expertise, we iterate solutions. And those solutions aren't what we did. We're not going to create better built environments if we just do what we did on the last project. So those solutions are drawing upon first principles thinking, drawing upon physics, and trying to innovate solutions that fit with that client's values in that setting for that unique project. Every building is, at the end of the day, a prototype. So that's what we do. And then validation for us is the construction phase. So after we've completed design, it's still important that we validate it's built that way. There's a lot of changes that can occur from what you all draw to when it's built, as you know. So that's an important phase. And then after the owner takes occupancy, we call that evolution. There's still a ton to learn. Every building's a prototype. We got to learn from the operation. The cycle continues and feeds into the next project. So we call that project framework. What I'm going to talk to you about today, you've already heard. We like cycles, and so there's this cycle, and we need to break the cycle. Right now, hospitals' healing spaces are enlisted to take care of the sick, to address illnesses. If you get a virus, which is in the news, and don't watch the news, it's super anxiety-inducing. But if you get an illness, you go to a hospital, healthcare providers take care of you. This is the purpose that they fill, yet 8% of that 40% that Frank put on the screen, 8% of 40%, sorry, 8% of all buildings, and buildings consume 40% of all energy, right? 8% of all buildings, energy is consumed by hospitals. They're huge consumers. That's not 8% of the floor area, right? It's 8% of energy because they're huge consumers of energy, which is contributing to the warming oceans. It is contributing to climate change. Climate change, as you also heard, is disrupting ecologies. As those ecologies are disrupted through climate change, we are at an increased risk for viruses, bacteria. If, as an example, if tomorrow something disrupted all the insects on the planet, humanity would cease to exist pretty quickly. We're very dependent on insect ecology. If it disrupted all of humanity, the planet would probably thrive. So you just wrap your head around that for a minute. So we have to do better as human beings, and we got to disrupt this cycle. So that's what we're here to talk about. There are significant challenges, as you heard, to solve this problem and disrupt this cycle. And I am excited to be here for lots of reasons, but one of them is I hope to inspire and activate you guys in your careers as architects, because I need your help. I was asking Willa if affiliated engineers had worked on a net zero hospital. I haven't had the opportunity to work on a net zero energy hospital. There's some blockers we're going to talk about, and I need your help so that we can do that before 2030. And to understand those blockers, the story is going to start by understanding the flu virus. This is the flu virus. A little PSA. By show of hands, who here has had the flu vaccine this season? Okay, who hasn't? You should go get the flu vaccine. Be with the flu in a hospital over the next couple of months, and I don't need to say any more than that. You want to get the flu vaccine to keep yourself out of that situation, because the ERs are not a place you want to be. So that's the PSA. So how are these things transmitted? The flu virus is transmitted on droplets. Human-to-human transfer is, the flu virus is in droplets, and when we cough or we sneeze, we're expelling that into the air. They don't survive very long outside our bodies. So human-to-human transfer is generally within 6 feet or less. Those droplets go through the air and then enter the other person through their mouth or through their nose. These are droplets. They can also, droplets can deposit on surfaces, and then when you touch those surfaces and it transfers to your hands, you're not infected at that point. But if you put your hands in your mouth or on your eyes or up your face, then you're infected. So that's how transmission occurs for viruses. And it's important to understand that, because as an HVAC engineer, these healthcare environments are built to prevent that, right? That's what or indoor environment. This environment should be conditioned in such a way to slow the transfer of infections. Every environment should be. So it's important to understand that and get to that here as we continue in this story. Bill Gates, I wanted to shine a light on this. He's been preparing the world to respond to these pandemics or epidemics. It's an epidemic when it's not global. It's local. It's a pandemic when it affects the world. He's been sounding the alarm to prepare us for like 4 or 5 years. In his 2018 annual report, he wrote that a flu-like virus is most likely to kill 10 million people in the coming decade. He sees that as a big risk. And the Bill and Melinda Gates Foundation is spending millions of dollars to create vaccines and stuff, and to prepare us for that eventuality. So it's going to happen. That's dire. That's why we need to address this problem of hospitals that consume a lot of energy and really take from the ecology and contribute to climate change. We can solve it because of that. So sticking with Bill Gates, there's a lot of 2030 goals out there. BranchPattern has a ton of 2030 goals. There's AIA 2030 Challenge. Microsoft Corporation a couple weeks ago have pledged, as they've looked at it and looked at the science and listened to the scientists, they have pledged to offset all of their energy usage to become net zero by 2030, and going one step beyond that, they're going to estimate all of the energy they've used since they were founded in the 70s, and by 2030 invest in enough renewable energy projects to offset all that they've ever used. Why would they be so extreme about that? They've said, Microsoft, that they have to be that aggressive because the situation is that dire. You saw the drought graphic that was shown earlier. The situation's that dire. They have to be that aggressive. We haven't made the progress that we committed to make when people smarter than me came up with all the 2030 goals 20 years ago. So, and you guys know that. So that's why we need to do better. And we're going to do better. There is hope. And you guys are part of that. Ideas can change, can make significant change, as we've seen many, many times over in our lifetimes. And so I'm going to ask you guys to hopefully take this content, take what I'm able to share with you today, and help me make the changes we need, because we need small hospitals like this one in Pender, Nebraska. It's about 50,000 square feet. We need those to be net zero energy. We need medium-sized hospitals like this one in Harrisonville that also has a 50,000 square foot MOB. We need these to be net zero. And BranchPattern, I was the designer on both of these. We did a little renovation to this one, but this is 2.2 million square foot of hospital space in San Antonio, San Antonio Military Medical Center. We need this campus to also be net zero, and it's incredibly difficult. One thing that all three of those size hospitals have in common is if you look at the site from an aerial, only about 15 to 25% of that site, for all three examples, could really be easily covered in photovoltaic. This is a 2019 image of a hospital in Arizona where I'd say that's about 15 to 20% of that site covered in photovoltaic. Wouldn't you? Is that what it looks like to you? You guys might have better spatial recognition than me, the engineer in the room. So does it look like 15 to 25% to you guys? Give some head nods? Okay. So you think that if we can cover 15 to 25% feasibly, and that's what this is, that this would be a net zero hospital. And it should be, but it's not. We need 3 times as much photovoltaic than what's shown here. Just looking at that, do you think it's realistic or feasible to get 3 times the photovoltaic on that site? So that's a problem. It's a problem that's the problem that I need you to help me solve. And there's a reason for it. We're going to get into that really quickly. But hospitals, compared to every other building type, consume a ton of data. This is the CVEX data, a ton of energy. This is the CVEX data on energy consumption. 232 is the EUI of hospitals according to the 2012 CVEX data. All of the other facility types, and these bars that you're seeing up here, these aren't net zero facility types for the other ones. These are the, you heard Steve talk about an office building that the EUI is 97, they brought it down to 17. So this is that 97 in that example. So all of those, if they're net zero, are consuming considerably less energy. So why are hospitals more? The 15 to 25%, super scientific. We'd have to get the EUI down to 65 to 100, and then that previous image could be net zero if the EUI was less than 100, closer to 65. Then we could be net zero. So let's investigate this further and figure out what's going on here. So if we look at the energy consumption of hospitals and break it down by different utility types, we'll see pretty quickly that 2/3 to 3/4 of the energy is being consumed by the HVAC system. And that breaks down further that 42% of the overall energy pie is reheat. Does everybody know what reheat is? Yeah, reheat. So we're cooling air down, and then we have to heat it back up, because if we continue to supply that volume of air to the space, cold air to the space, it's going to overcool. So we have to heat it back up. So we're expending energy to cool the air and then heat it back up. 42% of the energy pie is from that phenomenon in hospitals. So that's what we got to address. We can't talk about net zero energy hospitals without addressing reheat. And we as mechanical engineers, we have lots of innovations that we do at the plant level to recover energy, so that the energy, the waste heat from cooling goes into the hot water system. And we can do all of those things. We can do all of those things. We can we can recover that heat, and so that we're using energy. But that's still not going to solve it, because we've done all those things, and it doesn't get you to 100 UI. We've got to address what's causing the reheat in the first place. And that story takes us to the double standards for ventilation. Every other building you saw up there has to conform to ASHRAE standard 62.1. Hospitals have to comply with ASHRAE standard 170. And FGI 2018 and several of them now it's like a consortium of they've standard, but they've actually made it better, because it used to be like 3 different codes you have to, and then you didn't know which one applied. But now there's one standard for ventilation in healthcare. FGI codifies it. So if it's a J-code codified space, this is now code. 170's code for hospitals. The main difference between the two is 60.1 is more performance criteria based and CFM per person based. ASHRAE standard 170 is very prescriptive, and it's air changes per hour. That's the difference. So we're applying air changes per hour, minimum air changes per hour during all periods of occupancy to hospitals. And that's all codified across a lot of different spaces for inpatient nursing, for outpatient facilities, as well as the hospital spaces. And this is just the first page of the tables. If you talk to healthcare engineers, it's just referred to as the table. And the table, you got to apply it to the table, which has 2 air changes, 4 air changes, 6 operating rooms, or 20 air changes per hour. You have to apply that to all the hospital spaces per code. And this matters because as we talk about EUI, just applying 2 air changes per hour to a space continuously would result in an EUI of 130. Applying 7 air changes per hour is an EUI of 320. Remember, we got to get it down below 100. So air changes matter. You can't talk about net zero energy hospitals without addressing this problem. So what are the origins? Let's challenge the air changes per hour. Why do there need to be double standards? What are the origins of air changes per hour? What's the scientific evidence that says we should have air changes per hour? So there are, again, people smarter than me that have done a lot of this research, and I'm going to share some of that with you now. So they trace the origins of the 2 air change per hour to Florence Nightingale. You guys know who Florence Nightingale is? Yeah? Okay, so the lady with the lamp, she opined that the indoor environment of her time, late 1800s, was so poor that people were getting infections. And so Billings in 1893 responded by coming up with the 2 air change per hour rule of thumb for natural ventilation in architecture. So guidance for architects to create natural ventilation strategies that would result in 2 air changes per hour. So that health code, ASHRAE standard 170, and the 2 air changes per hour that's littered all throughout it for outside air is traced all the way back 140 years and hasn't really been tested or scrutinized under a microscope since. I wish it wasn't that way, but that's the reality, that's the finding. And the rest of the requirements, this is a table that just kind of shows the rest of the requirements from 1959 to 2013, those have been investigated. And the orange is 6, these are color coded by the value, so 6 air changes per hour is the orange. And you can see the red is a lot higher than that. So it's trending in the right direction. But starting in the 60s, we were applying air changes per hour, and hospitals were consuming a lot more energy starting in the 60s. It's an interesting conversation I had to have with the Cass Regional, the hospital you saw there, as well as the Pender, and all of these critical access hospitals in rural America that were originally built prior to 59, and to tell them, we're going to build you a new hospital, and your energy bills are going to go way up from what you've experienced before, because these codes have required the energy usage to go way up. Air changes per hour cause the energy usage to go way up. So what you're thinking is, going back to that character I introduced earlier, of the flu virus, is that we need these air changes per hour and these healing environments to prevent infection. So Kaiser Permanente has committed to being net zero across their entire hospital infrastructure by 2030. They've been investigating this, and their head mechanical engineer, Travis English, sent a survey out in 2013 to ask engineers that very question. Do they believe the air changes per hour is needed for infection control. 69% said no. It plays a minimal role in infection control. I don't know how you feel about 7 out of 10 of your engineers. There's still 3 out of 10 that say maybe it does, so maybe that's not good enough or confident. That was 2013. So we should investigate this a little further, right? So ASHRAE actually started a research project to do just that, to investigate it further. So RPCO, RP3, it was an ASHRAE research project, $125,000 over 2 years. They published the results at the beginning of last year. They identified 886 unique requirements in ASHRAE Standard 170. That's between air changes, humidification, filtration, 886 unique requirements. And what they sought to discover is, does it stand up to it? Does each of those requirements have evidence to support its inclusion? Does it have clinical evidence? There's 3 categories. Is it clinical, rational, or evidence-based? Does it stand up to inspection? Well, what the initial findings have reported is that about 2/3 to 3/4 of those 886 requirements don't stand up to inspection. There's not scientific evidence to support their inclusion. So the codes haven't changed. That was published in January of last year, and it may take a while before they do, but there's evidence. We want to apply this evidence to our design to create net zero hospitals. And Kaiser again looked at 2.2 million square foot of hospital space and found that 80%, almost 80% is office, circulation, waiting, and storage. So square foot area, most of the hospital is office, circulation, waiting, and storage. Less than 3% is operating, procedure, lab, and isolation spaces. And that's important because the cleanliness in an operating room, an airborne infectious isolation room, a protective environment room where you might have a burn victim, positively pressurized protective environment room, drug compounding rooms like USP 797 or USP 800 type spaces, pharmacy spaces. In those places, air changes per hour does play a role, and there is scientific evidence to support that. But for a lot of the other spaces, there just isn't the evidence to support it, but we're still applying these air changes per hour. There's hope. In Europe, they don't have ASHRAE 170 to contend with. So as you can see here, Germany, Sweden, Switzerland, and the UK new projects, they have 2 different categories, are within that 65 to 100 zone already. So that image of a net zero hospital, we could do this in Europe. The US is way over there, and I don't know if any of you take solace, but we are beating Canada. So there's hope. What I need for you guys to do, and what I'm, in fact, as soon as we're done here, we're working on a critical access hospital in Navajo Nation territory in New Mexico, Arizona. So I'll be getting on a plane to go down there with them. So I'm going to do what I'm asking you to do here is for them to create a net zero energy hospital. I'm going to only apply the FGI air change per hour requirements where it's absolutely and explicitly required by code. Okay, sometimes your engineers or architects are grossly applying it. Like, it depends on how you define a space. Do you think that space falls into this category? Is it an area of the hospital that's administrative and you're going to apply the office code, or are you going to treat those corridors with a 2 air change per hour? So only apply it where you absolutely have to. Then, and I have the HFDP certification, something that I have. I also need each of you, you're going to work with engineers, and they're going to have certifications and letters behind the name. It just means they're good at tests, that's all it means. And you're going to treat them like the subject matter expert. I actually want you guys as architects to challenge them with this knowledge if you're working on hospitals, right? Because the test that they took to get those letters, according to ASHRAE, it certifies that you know how to apply the air changes per hour. And that's what I'm saying is the problem, right? So I want you to challenge them with this evidence. Not everybody knows. 31% didn't respond to the survey saying correctly. And then the fastest way to make change, because this is a blocker, this is going to keep us from achieving net zero hospitals. How many people does affiliated engineers have? 700. This 700-man affiliated engineers firm, we're a lot smaller than that. What's that? People, sorry. 700 people. we're 80 people. Hasn't worked on a net zero energy hospital. I mean, just letting that sink in. And we need to because of how much energy they consume. The fastest way to make change is to bring the evidence to the authorities having jurisdiction that enforce the code and have them not enforce that code in place, not aggressively enforce that code. Right. There are other strategies because we can monitor occupancy, we can do some other things. So that's what I want you to do. And together we can achieve these 2030 goals, these lofty goals, and help Kaiser Permanente and others get to net zero energy, not just by investing in renewable energy projects in middle America, but also by addressing it on the site. So what if we could apply 62.1 to a lot of the hospital? I wanted to walk through that. What if we treated the hospital like schools? Like we've got lots of net zero schools out there. We've got lots of net zero office buildings out there. And in fact, as Steve was talking about, net positive, where they're producing more energy than they're consuming, which is really where we need to go because some of what we're building new has to make up for the fact that we've got all this existing inventory of buildings that are consuming energy. So what if we could apply that? And actually, beyond that, like wrap your head around what if we could make changes in the existing inventory? And it's just at a computer terminal. If we didn't have to apply the minimum air changes, we would instantly save a tremendous amount of energy across the entire portfolio of hospitals. So if you can convince an authority having jurisdiction that it's not applicable, then you can go in at a computer terminal for very little cost, adjust the minimum air flows down, and stop reheating. Okay. So schools. So Florence Nightingale was actually talking about indoor air quality in schools back in the 1800s because she viewed the children as the spreading of epidemics. And so the indoor air quality in schools was a problem. So that natural ventilation response from the architectural industry was for schools. So let's look at that. And as we apply 62.1, we also know when it comes to health and wellness that taking the code minimum and exceeding it a little bit provides improved cognitive function and human performance in the indoor environment. And this is a Harvard study that shows our ability to process information, respond to crises, and think strategically is positively impacted by significant percentages with increased ventilation. So I just got done saying that high rates of ventilation are the problem, let's lower them. But I'm saying there is a justification for having a strategy that increases ventilation. And we applied that strategy to this school. And I'm just going to walk you through some examples. Steve talked about EUIs in the teens. A lot of times that's achieved with a ground coupled. This is not a ground coupled solution, but we did use natural ventilation to achieve higher levels of indoor air quality, lower levels of carbon dioxide as a measure for indoor air quality with very little energy use. So the design team was targeting 750 parts per million, where the 60.1 would allow 1,000 parts per million CO2 concentration in the indoor environment. So we were exceeding those. And that will result in a 15% improvement in human performance within the built environment. And they integrated, the design, the engineering, the structural integrated, and this is a solar chimney that was used to help draw air through the space, as well as provide natural light and that sort of thing. So design integration is super important. These flow vectors and air intakes show how that natural ventilation would move through the space. There's no electrical input for natural ventilation because how the solar chimney is utilized. And this is what a classroom looked like. It's got a ceiling fan to help create thermal comfort as to wick away the heat from the surfaces of our skin. Then they have several different ways to get access to that natural ventilation. They can open a window, as you can see there in the image. There's also a windowsill louver that they can flip the switch and allow, and keep the windows closed, but allow natural ventilation to come through that louver, through the sill, built into that assembly. There's visual indication of when it's appropriate and when maybe it's not appropriate based on the outdoor environment and what the mechanical system's doing if the temperatures or outdoor conditions weren't favorable. there's visual indications. We can't accomplish it if we don't follow a process. So this is sort of an infographic of what the DIVE project framework that I introduced at the beginning looked like for an engagement like that. During discovery, we're identifying impact targets. During design, we're looking at solutions, trying to estimate impacts. And then at the end of the project, we got to measure results. So what were those measured results? In Colorado, where this project was, the EUI of most schools or surveyed schools averaged at 79. On this project, we targeted an EUI of 25. It's not ground coupled. If this were geothermal, it could be even lower than that. That wasn't part of this project's budget. We modeled 27, so the final design model showed an EUI of 27, and the measured was 32. So as Steve said, we didn't do a good job modeling, but actually, when you model, you are approximating usage, so hours of operation. So I think the building was used more than what it was modeled to be used, and that's why the EUI is higher. If we achieved the same results on that project in Arizona, if we took the 232 EUI down by the same proportion, it would be 73. We target 73, we model 79, and we achieve 94, and it's within our range, and that would be net zero. So we know it's possible if we take some of these things we're doing in other building types and apply it to hospitals by removing the ASHRAE 170 constraint. And it's something that I hope to be able to do here in the next couple of years. Hopefully on this project we're going down and doing in Navajo Nation. That'd be a great story to tell. Maybe I can come back and share that one with you. So that's what I got.